I just want to real quick clarify, because sometimes there's confusion around the term ADHD. When I use the term ADHD, I mean ADD. ADHD, I mean all of these things. These days, the DSM calls everything ADHD, and then they would say it's either inattentive presentation or combined presentation is what we'd be looking at most commonly in college students. Most of you probably already know that, but I just wanted to just make sure we're all clear on that. ADHD is funny in the college population in that many things you think research often starts in college, and then we expand out to other things once we learn about college, maybe for ease of access to participants, whatever that might be. But the opposite is the case with ADHD. We know very little about students with ADHD in the college setting. And it's really only in the last 10 years that you even start to see publications on this. There are many reasons for that. One might be that if you went back 20 or 30 years, there's some literature that suggests that not that many students with ADHD went to college. They took other paths. But now many of them are going to college, and so the question is, what do we do with that in the college setting, and how do we best handle that? The current evidence would say that about 5% of college students will meet criteria for ADHD, so take that and compare it to what you might think in the general population. A safe estimate is probably going to be around 8% in the general population. But you can see there's a lot of negative outcomes that are associated with ADHD in college. I'm going to go into this in more detail, but the last slide here is just more of relevant to this audience. This was a study that we did here at VCU a few years ago, and 70% of our sample had a D or an F in a core class, and rates of course withdrawal, starting a course and then withdrawing, was about 1 per semester. So that's significant. That suggests here are students that have done well enough to get to college, but they're really having a hard time once they transition to college. Why is that? Who are the types of students we see? I want to be clear that these are students who are often intellectually bright. Having ADHD does not mean anything about your intelligence. You can be gifted in ADHD, you can be average in ADHD, and those types of things. Many times these are students who were supported well by their parents and their teachers when they were in middle school and through high school. A fair amount of parent involvement. Think about things like homework or time management, helping them do these things on a day-to-day basis, making sure these things get done. And so these students have been successful, or at least successful enough to go to college. But then here we go and we go to college, and all those things are removed all at once for the most part. It's very difficult for a parent to support their child, and some would argue developmentally inappropriate. At sometimes you need to pull back. And it's very difficult for teachers to really get to know their students on an individual level and to work with them when you're in a class of 50, 100, 200, things like that. So it makes sense. The other thing is, the more we know about ADHD, the more we realize that they have deficits in what some might call executive functions. Executive functions is a really broad term, and we could all argue about what it really means. When I mean that in the context of ADHD, is they have a really hard time working towards goals that are far in the future and inhibiting their behavior so that they don't do things that they can do right now, go out rather than study, those types of things. So they have a really hard time with long-term planning, organizing their behavior to accomplish long-term goals. And frankly, that's what college is. College is a series of exams that are in the future or tests that we have to prepare in little steps. A couple other important things to mention about ADHD. We run an ADHD clinic here, and students will often say, I don't want to work with just ADHD, I want to work with other things, anxiety and depression. ADHD is rarely alone. In fact, it is the exception that ADHD is by itself. It is more common for ADHD to be with something else, such as anxiety or depression. And it's important to recognize that. The Anastopoulos study on the bottom here is one of the largest to date, and it's a longitudinal study across multiple college campuses, and you can see their rates for depressive disorder, and these are full depressive disorder, major depressive disorder, or what's dysthymia, or what's known as persistent depressive disorder, or anxiety. So the comorbidities are quite high in this population. The last thing I'll mention here is the difficulty, because this is relevant for our intervention, the difficulty students with ADHD have when they go to college with continuing their services. Just to think about, we struggle with these things all the time. Even if you were on medication, which by the way, most are no longer on medication, the majority when they're in high school, even if they were, Even if you were on, having your pediatrician or your family doctor who's now far away and having that managed here is a difficult challenge. If you were receiving counseling or therapy at home, coming here and finding new services and people to trust is a challenge. So that transition really is problematic. Currently, there are no evidence-based interventions for ADHD. If you looked at any current review for ADHD interventions in any of your preferred journals, they would not have an intervention for ADHD that would meet full criteria for being evidence-based. What do we do at college campuses? We do all sorts of things. We do accommodations. We do medication and counseling services. But there are many challenges associated with this. The first one is obvious to all things we do if you're interested in colleges, is that students have to seek these services. They have to go out and actively advocate for themselves to get services in most settings. Secondly, they often need documentation, right? You can't just go get a service. You often need a report or a formal report or something that says that you have ADHD. We actually have minimal evidence of what we're doing on a college campus. It may be very effective. We don't know. We don't know, frankly. People are often surprised by that. Given the high use of accommodations in middle school and high school and college, be that sitting in the front of the class, extended time on tests, there's actually very little research to say those things work. Those are just our go-tos, but we really have very little evidence to support them. So I'm going to talk briefly about the intervention that we're doing here and how we try to tackle some of these issues. The intervention that we're doing here, the access intervention, was developed by Arthur Anastopoulos at University of North Carolina at Greensboro. And the reason we're doing this study together was because at the same time we were doing a pretty much similar intervention, and we were both testing things at the same time, and it just happened to work out that way. This intervention is a combination of group CBT, for those of you who know cognitive behavioral therapy, and one-to-one mentoring services. The CBT portion is important. Why? Because most evidence-based treatments for children and adolescents with ADHD are not cognitive in nature. In fact, there's evidence to suggest that cognitive interventions don't work for younger kids with ADHD. So that's a shift. The cognitive behavioral is more associated with what we would do for adults with ADHD. Here are the things that the group provides students. So students receive 8 weekly group meetings. Each are 90 minutes in length, and 10 weekly individual mentoring sessions. These are brief check-ins with someone, about 20 minutes. That would occur in the first semester when it says active phase. The maintenance phase would be the second semester, with just one more group session and a couple more check-ins. And we can talk later on about whether that's feasible or whether or not we can disseminate that. We aimed for something that was reasonable, and many university counseling services do use group-type programs in their interventions. I'm going to put this slide up next. The intervention is designed to address 3 main things. 3 things are touched on in every session. One is ADHD knowledge, which is not something you might necessarily think of. But when we work with families, we're often providing parents about psychoeducation or teachers psychoeducation about what is ADHD, what is the rationale for what we do. Kids don't often hear that or know that. And we would argue that in order for someone to advocate for themselves, go seek services and know what they need and what their challenges are likely to be, they have to have that knowledge as a base. And they may not have that knowledge, and we find that consistently. Behavioral strategies. That's where I started out, thinking previous iterations of this intervention. We'll just teach them how to be organized and to set goals. So that part is in here, but it's not sufficient by itself. Cognitive strategies. I'm sure many of you are familiar with cognitive strategies, CBT strategies. Why do we do those things? The reason is that by the time most students with ADHD have gotten to college, they have experienced failure over and over and over, or at least struggles in their lives over and over and over. And when that happens to a person, they start to become less motivated to do things. Why try? I'm just going to fail. They become apathetic about these things. That's how we would argue depression develops. There's certainly a genetic component, but if you experience failure over and over again, your self-concept is eventually going to take a hit, and you're going to feel down on yourself, i.e. depression. So the reason we struggled when we first did just behavioral strategies These are not the first time these students have heard these strategies. That's ridiculous to think that. But they don't believe that they can use these strategies. They're not motivated to use these strategies because they think, all in my past I've tried this, people have told me this, it hasn't worked. So unless you address those maladaptive cognitions, how they feel about themselves, their self-efficacy, it's unlikely they're going to use any of these skills. A few people nodded, so apparently I'm making some sense. Here is the pilot study out of UNC-G before I show you our work here. It's just a small sample. Essentially, this was to try this out without a control group, and then I'll show you our data with a control group. You can see 58% had at least one comorbid diagnosis, typically anxiety or depression. I'm just going to tell you some of the things we're hoping to change from the pilot work. We're hoping to change measures of executive function. I'm sure many of you have seen the brief. It's a widely used measure. There are other versions for college students. But here you can see gains in executive function. These last two columns are simply effect sizes. Anything above 0.8 would be considered large. Something around 0.5 would be considered moderate gain, something like that. So we're hoping to improve executive function. But we're also hoping to reduce depression and anxiety. I'm sure many of you use the BDI or the BAI. And you can see we're getting moderate gains in the pilot study on depression and anxiety. That's important. Here's GPA. If you want people to take notice on a college campus, if you want administration to say, hey, this is something we're interested in, we want to support this, you better have this. Or you better have course withdrawals or a number of years it takes to graduate, because those are the meaningful metrics. And so you can see different gains in GPA across time. And then finally, what's really important to us is we want these students to access services. This is a short-term intervention relatively. We don't think that we're going to cure this and it's going to be done. One of our main goals is to say, I want you to be hooked up with services that are going to work for you when you're done with us. That's probably one of the most important things we do. We want to help you navigate this system. And it is a kind of crazy system with places all over the place you can go to and people that do this and people that do that. We literally help them navigate that system. And that's a big part of what we do. You can see increases in medication, slight increases in psychotherapy, a significant increase in people who are registered with disability services, and disability services used that they're reporting to us. So this is actually one of the things that's contrary to what you normally do when you see an intervention study. You want to see big gains in certain symptoms. I want to see this. I want to see that they're hooked up with services when we're done for the long term. So here's our grant. We're moving on to what we're doing now. There's 2 sites here at VCU and at UNC-G. And we are going to have 120 students with ADHD who receive intervention and 120 students who are delayed treatment, meaning they wait and then we serve them. Here's our timeline. The only reason I put this up is because we're almost done and I'm very excited. So here we are in spring, and we're over there. But we are currently recruiting our last cohort, the last group who will receive intervention next fall. And so by the end of the next year, we will be done and we will have the full sample. Here's some data at VCU. It's been wonderful. It truly has. I was skeptical going into this. One thing I was skeptical about, I'm going to show you data on in a second. Are students actually going to attend these sessions? And are they going to attend consistently? Going in, I probably would have said probably not. We've completed 175 2- to 3-hour mental health assessments. That's our inclusion evaluation. We assess for ADHD, depression, anxiety. We also do IQ and achievement. We want this study to be helpful to them. So when they do our inclusion evaluation, they leave with a report that says what they meet for that they can then take and use as they see fit. You can see 130 met for ADHD and we're eligible. Here, 40% met for a comorbid depressive disorder, 29% met for comorbid anxiety. One of the reasons I'll be glad to have done this from my own personal thing is that I get a lot of calls. It's very sad and concerning the amount of suicidal ideation in our sample. It is, it's not 40%, but it's close to people who will endorse, yes, I've thought about this on a college campus. And that's something that is concerning and that we need to take very seriously. Here's how we break down in terms of where they are in their program at VCU. You can see it's front-loaded towards freshmen, which we would expect. But we do have a wide range of grades. 45% are on medication. That's about consistent with national norms that would say people drop off medication in high school. And here's attending at least 80% of the available group and mentoring sessions. There's some variability in there for sure, but overall, they're coming, which is great. So when I'm presenting preliminary outcomes today, this is very small. It's 30 in the access and 25 in the control. It's just essentially what we've entered so far. And there are significant group by time interactions, if you care about that kind of stuff, on all of the graphs that I'm showing. So here's our executive functions. Kind of neat here, what's interesting here is that from pre to post, the pre to post is just the first semester. There's no split. It's during maintenance, the second semester when there's a split. In some ways that makes sense because you're not going to uptake all these skills and apply them all at once. It's going to take time to do that. This graph is the reverse, so you actually want to go up. And this is a measure that just looks at overall functional impairment. Kids with ADHD and adults with ADHD struggle in many areas, interpersonally, with peer relationships, with conflict, and with academics. So this measure captures that broadly. Here's our BDI, or depression, for those of you who are familiar with that. Here's ADHD cognitions. So this is maladaptive cognitions about ADHD, someone who would be likely to think negative thoughts about the fact that they have ADHD, that they're not going to be able to do certain things other people are going to do, or we want to decrease that. We want them to be realistic, but we want them to take a more positive view. So this is the part that's most interesting to me, and I hope that if there's a question period, these are the things we can discuss here. Future directions and implications. A big thing for me and all the research I do a lot of intervention research, is that we need to design things that people can actually use. That's something researchers have struggled with and failed at, frankly, for years and years and years. So we tried to design this 8-session group CBT and mentoring as something that is possibly feasible. We'll see. Perhaps there are other models we can use that would make it more feasible. One thing I did when I first came here was that an expert, if you will, ran the group, but junior and senior students who were doing well here at VCU served as the mentors, so a peer mentoring approach. That's a neat kind of service learning opportunity for those students. Psychology majors are often really interested in getting hands-on experience, and also it kind of increases feasibility a little bit if someone else runs the group and the mentoring is provided. So that's one model we might consider. Other things to consider, that these are things that I've been talking about with Danielle, and I really hope to address. We know that mental health on a college, it's starting to get more and more public attention. Mental health on college campuses is an important, serious issue. But how do we identify the students? How do we, rather than waiting for them to come to us, recognize students who are having a problem early and help them get connected with services? The other side to that coin is college campuses are big places. And if we screen everybody for mental health and we try to connect them with services, we're not going to be able to provide that many services. So we have to find some type of a balance, because there are lots of students walking around who need our help and they're not being seen and they're not coming to us. So the question is, where is that balance? In my study, for example, we rule out students who meet for bipolar disorder, for example. And unfortunately, I've had to do that 10 to 15 times. So those are students I'm not able to help and may not be connected with any services on the VCU campus. This is a big challenge here on universities. What do you require before someone gets services for ADHD? And most importantly, what do you require before someone gets medication? We can argue about this all day long because this is a controversial issue. The issue is that there is evidence in the literature that students will malinger, or that students will say, I have ADHD, so that they can get medication. That is an acknowledged problem. On the other hand, we don't want to make it too hard for students to get services, because we know that it's already difficult for them to get services in the first place. How do we deal with that in our study? In our study, in order to meet criteria for ADHD, rather than just self-report, we actually required that we were able to call a parent or a caregiver and interview them about their childhood functioning. And if we could not document evidence of clinically significant symptoms and impairment in childhood, they were not eligible. That is designed to protect against students who are just saying, yes, 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 I saw this on the internet and I currently have all these things. Remember, ADHD is defined by the DSM as a disorder that's present before the age of 12 and persistent across time. If you have symptoms that appeared when you were 18 years old, that's not ADHD, that's something else. It doesn't mean you don't have a problem, but that's not ADHD. So we can start to think about what are some ways we can get at childhood things, what are ways we can confirm students' reports. But we are really in a bind because we need to do it, but it can't be that resource intensive to have to do it. ADHD and substance use. If any of you are interested in a career, there really is not all that much out there. And there's plenty to be learned. The evidence to date, for those of you who are interested, suggests that students with ADHD don't necessarily drink or use illicit substances at a higher rate than their peers, but that they have significantly more problems than their peers when they do so. In many ways, that makes theoretical sense. If you have a disorder that is characterized by behavioral disinhibition, being impulsive, when you're under the influence of a substance, you're more likely to do those things and to get into trouble. Does that make sense? But we got a lot to learn. And this is just my stuff. I'd be happy to answer any questions. I appreciate your time, and thank you.